and critical care societies. Furthermore, Dr. Nakagawa has always served as a bridge between Japan and global collaboration, assisting physicians in understanding the use of high-frequency oscillation in pediatric applications. Now, high-frequency oscillation, I invite you to listen to Dr. Nakagawa's webinar. I invite you to listen. Please, Dr. Nakagawa.
Thank you very much for the introduction. My name is Satoshi Nakagawa. I hope you can hear me well. It is my privilege and honor to talk on the high-frequency oscillation pediatric application today. These are today's content. I will talk about what is high-frequency oscillation, pediatric application, settings, adjustment, weaning, monitoring, complications, and troubleshooting. So first item is what is high-frequency oscillation. HFO stands for the high-frequency oscillation, and high frequency usually means the frequency faster than 1 to 2 hertz, which is 60 to 120 per minute. Oscillation is active in inspiration and expiration. And tidal volumes are smaller than the anatomical dead space in theory. However, the reality may be different in some countries. So I will talk this later in my talk. This is a diagrammatic illustration flow of the gas flow in high-frequency oscillation. If the piston moves, the lung oscillates like this. This is the typical airway pressure waveforms in conventional mechanical ventilation as well as the high-frequency oscillation. In the blue line, this represents the pressure-controlled ventilation. As you can see, there's a PEEP and PIP in the conventional mechanical ventilation. In the high-frequency oscillation, the waveform is illustrated in the black line, and the airway is going to be oscillated like this. So this time frame is 1 second, and there's a 8 hertz in frequency. So this diagram provides the 8 hertz of frequency in high-frequency oscillation. And there is no PEEP and PIP in the high-frequency oscillation. The mean descending airway pressure is mean airway pressure. This is the nice diagram of the pressure volume curve. This is the inspiratory limb, and this is the expiratory limb. And this is the typical loop of the conventional mechanical ventilation. So this is the PEEP level, and this is PIP, and this is end-expirated lung volume, and this is recruited lung volume. In high-frequency oscillation with the same airway pressure, the loop is going to be like this. The question is it okay at the same level of the 1 mean air pressure of the conventional mechanical ventilation? Probably it is recommended to set relatively higher, 3 to 5 centimeters higher than the one of conventional mode. So not with the same level. Probably it is better to increase the minimal pressure of the conventional mechanical ventilation to the high frequency oscillation, because with the conventional mechanical ventilation, a peak inspiratory pressure inflates the lung. However, there's no such function with the high frequency oscillation. This is why we prefer to set the higher minimal pressure at the starting point of the high frequency oscillation. Ventilation in high frequency oscillation. CO2 removal in the conventional mechanical ventilation mode is usually related with the minute ventilation. Ventilation is calculated by the tidal volume multiplied by the respiratory rate. The CO2 elimination in the high frequency oscillation is usually the frequency times by the square of the tidal volume. So tidal volume is very important in the high frequency oscillation in terms of the CO2 elimination. So when we compare between the 10 Hertz and the tidal volume of 80 ml and 8 Hertz and tidal volume of 100 ml, when we calculate this frequency times multiplied by the square of the tidal volume, it's going to be like this. Then further calculation, 8 Hertz and the tidal volume of 100 has the greater number of this equation. So tidal volume is important, in terms of the CO2 elimination. However, if you increase the tidal volume, this may not be beneficial in terms of the lung protective mechanical ventilation. So this will be discussed later on in this talk. Major pediatric application of high frequency oscillation is in pulmonary edema, either in cardiogenic or either in non-cardiogenic. A typical non-cardiogenic pulmonary edema is ARDS, as you know. Especially the moderate to severe form of ARDS is going to be the indication of high frequency oscillation. This is the public recommendation, the guideline published in 2015 in Pediatric Critical Care Medicine. And in the chapter of the ventilatory care, Dr. Riemensberger and Dr. Chiefetz described the recommendation on the high frequency oscillation like this. So recommendations, we recommend that high frequency oscillation, oscillative ventilation should be considered as an alternative ventilatory mode in hypoxic respiratory failure in patients whose plateau airway pressure exceeds 28 centimeters of water. So when the peak airway pressure or plateau airway pressure hits 28 to 30 centimeters of water, we usually consider to switch the mode from conventional to high frequency oscillation mode. This is the adult study combining 4 trials. This is the patient data meta-analysis paper, which was written by Dr. Maureen Mead. 4th study includes the OSCAR and OSCILLATE, 2 large RCT studies in the adult population. And if the patient has the PF ratio, PAO to FI ratio below 100, there's a high chance of the survival by applying the high frequency oscillation. So even with the adult population, high frequency oscillation is beneficial to the patient with the severe form of the ARDS. Our initial settings are like this. When we want to start the high frequency oscillation, we usually start with the FiO2 somewhere between 0.6 and 1.0. And minimal pressure is usually increased 3 to 5 centimeters higher than the minimal pressure of conventional mechanical ventilation mode. Or I will tell you later, we sometimes increase media pressure 10 centimeters than the one of the conventional mechanical ventilation mode. We use the frequency 10 hertz or higher. And if we have the patient with a very high CO2 level, we may consider the lower frequency. However, lower frequency provides a bigger tidal volume, which are potentially injurious to the lungs. And we select the amplitude dependent on the patient. Dr. Haga was a colleague, and he did a study on our patient who were in our pediatric ICU between 2011 and 2014. He collected the data on the 36 patients on high-frequency oscillation in a pediatric ICU, and 21 of them survived and 15 died. So survival rate by the high-frequency oscillation was 58%. Average age was 38 months, so which is around 3 years old. And the patient was weighing 12 kilograms in average. And male gender was around 30%. P-load level was 17 in average. And half of the patient was immunocompromised host. And this is our feature of the ARDS patient population in our institutions. We have 1/3 of pulmonary ARDS and 2/3 of the extrapulmonary ARDS, including the sepsis and the liver failure. Our center deals with the liver transplant, so we have many acute liver failure patients, and some of them were associated with the very severe ARDS, required high-frequency oscillation. And these are the settings before the high-frequency oscillation and the initial setting of the high-frequency oscillation. Before switching to the high-frequency oscillation, the patients were on the pressure-controlled mechanical ventilation, and PIP was 31 and PEEP was around 10. So if the patient is on the 30/10 of the pressure-controlled ventilation, we usually consider to switch the conventional to high-frequency oscillation mode. And mean pressure on the conventional mechanical ventilation was 17 in average. And when we start the high-frequency oscillation, we increased the 10 centimeter above the mean pressure of conventional mechanical ventilation in HFO. We set the FiO2 at 0.9 in average, and amplitude, the average was 75, and we choose the frequency above 10, so our average frequency is 11.9 in our series. We can find the very informative paper from the United States. This is the publication from the Nationwide Children's Hospital and Children's Hospital of Philadelphia, two major centers in the United States. And they describe their experience on the high-frequency oscillation in the pediatric population. So in their series, they analyzed the data on the 134 patients, and 78 of them survived, and 56 of them unfortunately died. When we look at the age, the survivors tend to have the younger age, and they apply the high-frequency oscillation on the severe ARDS by the Paddock definition. Oxygenation index equal to 16 or greater than 16. Survivors tend to have the shorter duration of the conventional mechanical ventilation before applying high-frequency oscillation, 1 day versus 4 days in medium. And same as in the United States, they apply the high-frequency oscillation on the immunocompromised host. in the non-survivors group, 80% of them had the immunocompromised condition, and around 30% of them, of the survivors, had the immunocompromised condition in their series. This is a change before and after the high-frequency oscillation. And before starting the high-frequency oscillation, mean air pressure was 21 and 22 on the conventional mechanical ventilation, and PF ratio was around 70, and oxygenation index was between 28 and 33, and PaCO2 was around 60 millimeter mercury. And after switching to the high-frequency oscillation, they applied the mean air pressure, the 28 centimeter of water, so which is roughly 8 centimeter higher than the conventional mean air pressure. And PF ratio was improved from 71 to about 45 in the survivors, and there's no significant change in the non-survivors. When we look at the oxygenation index decreased significantly in the survivors by applying high-frequency oscillation. However, there's no change in the OI in the non-survivors in the 24 hours of the high-frequency oscillation. And between the survivors and non-survivors, PaCO2 levels are statistically different. And they also showed the diagram of the oxygenation index change. So in the survivors, represented in the white box, shows the improved oxygenation index over the course of 24 hours of high-frequency oscillation. However, in the non-survivors, OI did not improve. They also compared the result of the two centers, Center 1 and Center 2. When we look at the mortality, the Center 1 has the higher mortality than the Center 2, 55% compared with the 27%. One of the reasons may be that the Center 1 has the higher incidence of the immunocompromised host treated with the high-frequency oscillation compared with the Center 2. And the other reason might be in the Center 2, they started high-frequency oscillation relatively earlier. The PF ratio was higher than the one of Center 1. So if the PF ratio goes below the 100 level, the Center 2 started high-frequency oscillation. And in the Center 1, they tended to wait further to PF ratio decrease further. So this may be another reason that Center 2 has the higher survival by the high-frequency oscillation, although we cannot draw the definite conclusion from this study. As I described earlier, the lower frequencies provide the bigger tidal volume, however, which are potentially injurious to the lungs. So this statement is based on the animal study. And this is the animal study, which was done in China. And they used the sheep weighing around 40 kilograms. And they tried the high-frequency oscillation at 3 different frequencies in 3 hertz, 6 hertz, and 9 hertz, compared with the conventional mechanical ventilation. In the conventional mechanical ventilation, they did the lung protective mechanical ventilation. The tidal volume was controlled around 6 ml per kilogram. And in the high-frequency oscillation, they fixed the amplitude, even though they changed the 3 different frequencies. So they used the 70 centimeter of the amplitude in the high-frequency oscillation. As a consequence, they measured the tidal volume in each frequencies. So with 3 hertz, tidal volume was 6.8 ml per kilogram in average. With the 6 hertz, tidal volume was around 3 ml per kilo in average. And with the 9 hertz, the tidal volume was 1.8 ml per kilogram in average. So you may assume that the high frequency oscillation is lung protective mechanical ventilation. However, if you choose the lower frequencies like 3 hertz and 6 hertz, tidal volume may exceed the anatomical dead space. And even with the 3 hertz, tidal volume is very close to the ones of the conventional mechanical ventilation. So if you want to use the high frequency oscillation, you must be mindful on the frequency when you are using. This is the histological comparison of the lung between the 4 different settings: conventional mechanical ventilation and high frequency oscillation with 9 hertz, 6 hertz, and 3 hertz. As you can see, the lung structure is well maintained with the high frequency oscillation of 9 hertz. And if you look at the conventional mechanical ventilation and the HFO with the 3 hertz of frequency, after the mechanical ventilation, the lung is not well protected by the mechanical ventilation. So a higher frequency in high frequency oscillation is lung protective. However, on the other hand, lower frequency is potentially harmful even in the high frequency oscillation. Let's discuss on the adjustment. If you encounter the desaturation during the high frequency oscillation, you may consider the 2 lung conditions. Number 1 is decrease in lung volume. Number 2, increase in the interpulmonary shunt without decreased lung volume. So in the condition of the decreasing in lung volume, you have to increase lung volumes, either applying the recruitment maneuvers or increasing media pressure to improve the lung volume. In the situation of the increase in the interpulmonary shunt without decreased lung volume, the recruitment maneuver or higher air pressure may not be helpful. So you must consider the prone positioning with the high frequency oscillation. This is a typical 2 lung conditions. Left-hand side on the screen is the patient with the dorsal atelectasis, and right-hand side of the patient has the homogeneous lung showing the homogeneous lung infiltration. So on the right-hand side patient, the recruitment maneuver might be helpful. However, the recruitment maneuver may be harmful in the patient on the left-hand side. This data was taken from the paper by Dr. Neil Ferguson. He did the recruitment maneuver with high frequency oscillation in the adult patient, and they apply the 40 centimeter of media pressure for 40 seconds. So-called 40-40 technique on the very severe ARDS patient. And by this technique, in the average PaO2 FiO2 improved from the 100 range to 200 range. So in this paper, Dr. Ferguson concluded that the recruitment maneuver in the HFO improved the oxygenation. However, when we look at the individual data, the group in this area has improved oxygenation, and the group in this area did not show the improved oxygenation, did not improve the oxygenation. So recruitment maneuver with high frequency oscillation may be beneficial in the some of the patients, but may not be beneficial the others. We had this patient several years ago. This is the 8-year-old female infant with the neurogenic pulmonary edema after the motor vehicle accident. And he had very severe hypoxemia, and her oxygenation was improved with the mean air pressure of 45 centimeters of water with high frequency oscillation. Before that, the oxygenation did not improve. So she was responded to the kind of recruitment maneuver with the higher mean air pressure. This is not the data with the high frequency oscillation. This is the study on the conventional mechanical ventilation, examining the efficacy of the prone positioning in the adult population. And if you see the survival curve, the prone position patient has the better survival compared with the supine group. When we look at the PEEP level, when they applied the prone positioning, PEEP was not high. PEEP was around 10 centimeters of water. So it is better to apply the prone positioning earlier rather than later. Prone positioning can be combined with the high frequency oscillation. This is also the adult study. And after 20 hours applying the high frequency oscillation with prone positioning, the group with the prone HFO has the highest PF ratio compared with the prone conventional mechanical ventilation and supine high frequency oscillation. When we look at the settings of the mean air pressure of the high frequency oscillation, before applying the high frequency oscillation with the conventional mechanical ventilation, their mean air pressure was around 19 centimeters of water. And with the high frequency oscillation, they applied the 25 centimeters of water, either in the supine and either in the prone positioning. So applying the prone positioning with the high frequency oscillation, the patient has the best oxygenation level with the combination. The adjustment of the CO2 level during the high frequency oscillation. If we have the higher CO2 level, we try to increase the ventilation. As I showed the diagram, the equation before, CO2 elimination is dependent on the frequency multiplied by the square of the tidal volume. So the effective method to eliminate CO2 is increase the tidal volume. However, if you use the lower frequency with the higher tidal volume, as you see, as you already have seen, the animal study from China, even with the high frequency oscillation, the lower frequency may provide the lung injurious strategy. So we may need to be ended up with the pervasive hypercapnia in the management. In terms of the weaning, if the oxygenation is stable, we usually decrease the FiO2 rather than the mean airway pressure. So decrease the FiO2 first, and if the FiO2 hits the 0.6 level, we usually start decreasing the mean airway pressure by 1 or 2 centimeters of water. However, if the chest X-ray reveal the lung hyperinflation, we may decrease the mean air pressure first, then the FiO2 decrease. Once mean air pressure is decreased to 18 to 20 centimeters of water level, and FiO2 is around 0.4 or 0.5 level, we consider the conversion from HFO to conventional mechanical ventilation. If the PaCO2 becomes lower than the 40 millimeter mercury, we decrease the amplitude. In terms of the monitoring, we need the continuous monitoring system. So for the oxygenation, we use pulse oximeter. in order to evaluate the ventilation, some center prefers to use the transcutaneous CO2 monitor. However, we use the black gas analysis relatively frequently to look at the CO2 level by the high frequency oscillation. I will discuss the hemodynamics later on. The hemodynamic instability may occur when applying the high frequency oscillation. So in our institution, we usually start with the invasive blood pressure monitoring by an arterial line, especially in the early phase, acute phase of the management of high frequency oscillation. The patient may have the pulmonary hypertension with the severe ARDS, or by the setting of the high frequency oscillation, the patient may have the right ventricular dysfunction. So we often do the echocardiography to evaluate the cardiac function. Electrical impedance tomography is not widely available at this moment. However, on one patient, we tried this mode. The patient is on the conventional mechanical ventilation. You can see the tidal breath. And each breath, you can see the orange or red zone. This is hyperinflated zone. And on the same patient, on the other day, we tried high frequency oscillation. And you can see the almost no color change with the high frequency oscillation. And at the end of the recording, we did the sustained inflation and tried to recruit the lung volume. I'm showing again. So almost no change in the coloring. And we did lung volume recruitment. So both lungs are hyperinflated by the lung volume recruitment maneuver. So with the regular high frequency oscillation, the color by the EIT may not be showing a significant difference. The major complication with the high frequency oscillation, what we see in the management, one of them is hemodynamic compromise. So we have to choose the mean air pressure very carefully. So if you're not used to the high frequency oscillation, it is better to titrate from the lower level of the mean air pressure, 3 to 5 centimeter higher than the ones of conventional mechanical ventilation. However, if you have the relatively good experience with the high frequency oscillation, you may try the higher level of the mean air pressure when carefully looking at the hemodynamic compromise. The other complication with the high frequency oscillations are air leaks. And if we find the air leaks, we do the aggressive chest tube insertion. This is the animal study. This study was done by the group of the Massachusetts General Hospital group, Dr. Bob Kazmarek group. And with the high frequency oscillation, they did the static pressure volume curve. And they found that in this lung model, they found that the lower inflection point was around 20 centimeters of water. And they set the mean air pressure at various levels, 2 centimeters higher than the lower corner point, which is the this corner, and 6 centimeters higher than the lower corner. Actually, this is the point of the maximum curvature, and 10 centimeters higher than the lower inflection point. As you can see, the cardiac output was maintained up to the 6 centimeters higher than the lower inflection point. So 6 centimeters higher than the lower inflection point is located here. So above this level, their lungs are hyperinflated, and as a consequence, the cardiac output decreases. And same thing can be seen in the oxygen delivery. If the airway pressure exceeds this point, the oxygen delivery also decreased. They also looked at the pulmonary vascular resistance. PVR also increased above this level of the mean pressure. So you have to choose the mean pressure very carefully with careful looking at the hemodynamic status in the patients. This is the data from our series. We looked at the hemodynamic status of the patient who required the high frequency oscillation. And when we look at the catecholamine index and lactate, although there are no statistically significant between the survivors and non-survivors, non-survivors tend to have the higher requirement of the catecholamine before starting the high frequency oscillation, and lactate level was higher than the survivors before starting the high frequency oscillation. So if the patient has the hemodynamic compromise already before applying the high frequency oscillation, you must be carefully apply the high frequency oscillation because the patient may have the further hemodynamic instability by using the high frequency oscillation. These data were taken from the oscillate study in the adult population. This is high frequency oscillation, RCT in the adult population. When we focus on the vasopressors, before applying the high frequency oscillation, requirement of vasopressors are almost same between the two groups, in the HFO group and control group. However, in the HFO group, the requirement of vasopressor increased after the initiation of HFO, and the further increase on the next day in the requirement of vasopressors. And further, when we focus on the 24-hour fluid balance, as you can see, the HFO group has the higher positive fluid balance compared to the control group in day 1, as well as the day 3, although there are no statistical difference between the two groups. But HFO-B group tended to have the higher positive fluid balance along the course. So we must be mindful in terms of the hemodynamic management, including the vasopressor use and the fluid management. Troubleshooting. We often see the sudden saturation decrease with the increased secretion in the trachea or the bronchi. So in that situation, we must do the intracheal suctioning. At the same time, we must consider the pneumothorax or air leak syndrome. So we usually set the threshold lower to take the chest X-ray film. When we see the intractable hypoxemia, we must evaluate the lungs conditions are recruitable or non-recruitable. If we think this is recruitable, we apply the higher mean pressure. And if we think this is non-recruitable, we consider to apply the prone positioning. And there's no further improvement. We must consider the ECMO is indicated on the patient or not. With the hypercapnia, the increased secretion also intervene the oscillation, the airflow oscillation to the lung. So we must do the rule out the increased secretion condition by the endotracheal suctioning. So today I covered the following topics, including the what is high frequency oscillation and pediatric application, settings of the high frequency oscillators, and adjustment based on the course of the patient, and the weaning, monitoring complications, as well as the troubleshooting. Thank you very much for the listening, and I'm happy to answer your questions.
Thank you, Dr. Nakagawa. So, audience, please, if you have questions, let's share in the chat. Here we have the first one. How reliable is the PV tool for the optimal setting when the patient is ventilated with uncuffed ET tubes?
Thank you very much for the question. With the uncuffed tube, PV curve may not be reliable. So if you want to draw the PV curve, you need to eliminate the leak around the entracheal tube by compressing the neck to the behind. Or without the cuff tube, it is very difficult to draw the pressure volume curve. Thank you very much for the question.
The next question. How could you measure DCO2 on a Metran view?
Probably this is the question to the manufacturer.
Yeah. Yes. I'm sorry. At this moment, the humming view is not. It doesn't have the measure of the DCO2. We have to improve this.
I think Dr. Fook is raising his hands.
Dr. Nakagawa?
Yes.
Hi, how are you? Good to see you.
How are you?
Yeah. So thank you very much for very interesting and informative lecture on HFO application in children. Actually, I have some question relating to the information presented in the lecture. So first one, in the one of the study you see with your experience in Tokyo, when your setting is quite high, mean airway pressure for initial setting, in conventional it's only around 17, and it was 10 centimeter higher. So is that any depending on the age, weight, and study population? So because on the literature and also previously experience, we usually setting about 2 to 4 centimeter higher than conventional mechanical ventilation. But in this one, you see up to 10 initial. So why we can setting up is such high?
Thank you very much for the question. As I showed in my slide, our population, ARDS population, somewhat different from the other centers, and 60 to 70% of ARDS population is extrapulmonary ARDS. So they tend to have the generalized edema of the trunk, and so their lung is kind of recruitable by the higher airway pressure. So that's why we apply the higher mean air pressure by switching to the high frequency oscillation. So if we have the purely pulmonary ARDS, we may cautiously to apply the airway pressure, probably starting the 3 to 5 centimeter higher than the one of the conventional mechanical ventilation. Thank you very much for the question.
And so how maximum you can set up for mean airway pressure, because you presented a case in initial setting with 45 degrees centimeter water, that initial setting. So how is the maximum mean airway pressure is you did in your experience? Because we use, but I think we never use that high up to 40 mean airway pressure in oscillator. I'm quite surprised with the 45 degree, 45 initial setting. So meaning that it might higher than that, right?
Yes. This was a very special patient. So there was no oxygen improvement by the 40 centimeter of the mean air pressure. So we decided to increase up to 45. Then the saturation improved from the 90% to almost 100%. So that's why we started the mean air pressure at 45 centimeter. Then as far as oxygenation maintained, we decreased the mean air pressure very quickly on this patient. So this was very special, but we sometimes use the 30 to 35 centimeter of water in mean air pressure in our ARDS population. Thank you for the question.
Yeah, so one more regarding to recruitment maneuver. When the patient on oscillator, do you apply a recruitment maneuver on oscillator, or you switch up to CMV and do the, because now I think the more frequent use, they use it like stepwise increasing a PIP on the conventional mechanical ventilation for recruitment maneuver. So what is your strategy for recruitment maneuver while the patient on oscillator?
Thank you for the question. With the Metran's oscillator, this has the sustained inflation button. So we usually set the sustained inflation pressure 5 to 10 centimeter higher than the mean air pressure. So I usually push the sustained inflation button for 10 seconds. So this is the kind of recruitment maneuver, 10 centimeter higher than the preset mean air pressure. And I usually see the oxygenation response by the pulse oximeter. So this is quick evaluation of by the quick recruitment maneuver. And if there's a response in the oxygenation, I raise the mean air pressure by 2 centimeter.
All right, thank you very much.
You're welcome.
Okay, another question. Have you ever extubated from HFOB?
This is theoretically possible, but in our institution, we usually convert to the conventional mechanical ventilation because including the nursing staff, everyone is familiar with the conventional mechanical ventilation, so they are happy to do the further weaning in the conventional mechanical ventilation. However, the extubation from the high-frequency oscillation is theoretically possible, and this style is done in the neonatal population in some centers, as I understand. Thank you for the question.
Another question. Is it advisable to use the proximal flow sensor in pediatric mode? What about secretions?
Flow sensor should be very helpful in order to know the tidal volume by the high frequency oscillation. However, in the pediatric population, even within the neonatal population, the flow sensor itself is increasing the resistance of the airway. So applying the flow sensor may decrease the actual tidal volume delivered to the patient. So it is sometimes it is very helpful, but you may not be able to choose the flow sensor in the daily practice because it may increase the airway resistance.
Thank you, Dr. Nakagawa. And another question. If you maximize amplitude and use minimum frequency, but you still are experiencing high CO2 and low pH, what should you handle, how to handle this situation?
This is a very tough question, and I think this is the limitation of the management. But one thing you can try is if you manage the patient with the cuffed endotracheal tube, you can deflate the cuff, and this may be helpful for the CO2 elimination. Although I did not discuss this in my talk. In the main topics, but this may be tried with the high CO2 level in the patient, difficult patient.
Thank you, Dr. Please, Dr. Resti Bautista.
Thank you, Dr. Satoshi Nakagawa, for your very enlightening lecture. I'm a neonatologist from the Philippines, and I'd like to ask about stroke volume, because that's the parameter we now see with the newer high-frequency machines. How does that relate to amplitude? And do we manipulate that parameter the same way that we use amplitude in the management of our patients? Thank you.
Thank you for the question. Actually, amplitude itself may differ by the machine to machine with the similar settings. So if you compare the two different manufacturers' machine with the same frequency and the same tidal volume, amplitude may be different. So it is very difficult to set recommend the appropriate amplitude on the patient. So you just focus on the tidal volume or the preset the stroke volume of the oscillator, then check the CO2 level.
Thank you.
Thank you for the question.
Please, Dr. Van.
Thank you, Dr. Thank you, Dr. Nakagawa. May I have a question that the prop position in the even in the HFO is really really helpful to the patient. For example, we do have a supine position, and any symptom or any sign in the clinical can guide the physician to switch from supine to the prop position.
If you have the difficulty in management of the oxygenation, it's better to consider the prone positioning. It takes the human resources because at least 4 or 5 people in turning the patient to the prone positioning. However, if your team is familiar with the prone positioning is very effective management tool in terms of the oxygenation management.
Thank you for your answer. May I have another one?
Sure.
Do you have another relationship between the vasopressure and the altitude or the mean airway pressure to make the balance? How is the priority to make the balance between those items in the patient?
I usually focus on the mean airway pressure in terms of the oxygenation level, and the amplitude was separately controlled for the CO2 ventilation. So there's no close link between the mean air pressure and amplitude. You can separately manage the level of the mean air pressure and amplitude.
Yeah, thank you. Thank you so much for the answer.
Very simple question.
Thank you, Dr. Nakagawa. Another question. What do you think about nasal HFO for the pediatric application?
The nasal HFO, may not be practical in the pediatric population because I may be wrong, but we have been applying the high frequency oscillation in the severe form of the ARDS. And the severe form of ARDS, they usually require the endotracheal intubation and relatively high mechanical ventilator setting. So without the intubation, it may be difficult to manage those patients. But in the mild form of the pneumonia or ARDS, you may be able to manage by the high frequency oscillation via nasal cannula, but we have not tried in the pediatric population. So if the neonatologist has a significant accumulation of experience with those techniques, we may apply those to the pediatrics. But I have not done this technique, and probably in the next 5 years, we may not try that strategy on the pediatric patient.
Thank you, Dr. Nakagawa. I think it comes the last question because of the time. Someone is asking about what is the difference between the IE ratio 1:1 and 1:2 in HFO?
This is a very important question, and I prefer to use the 1:1 IE ratio because the concept of the high frequency oscillation is oscillating around the mean air pressure. So if you set the mean air pressure to distend the lung, the oscillation should be 1:1. With the sensor medics, I think Americans started the 1:2 IE ratio in order to prevent the further lung distension. But in the pediatric population, our first goal is the recruiting the lung volume by the high frequency oscillation. So it is better to do the 1:1 rather than 1:2 in order to maintain the lung volume.
Okay, thank you, Dr. Nakagawa. There are other questions in the chat, but I think the time has come, so let's finish this session now.
Thank you very much. And I'm happy to answer your further question. So if you send your questions to me, I will answer by the text, and you can send it to the our audience later. Thank you very much for your assistance.
Thank you very much. Have a nice evening, everybody, and thank you for listening to our website.
Dạ, em xin cảm ơn các anh chị đã tham gia từ Việt Nam. Thì hôm nay thì cũng không có thời gian em có thể dịch được, nhưng nếu anh chị có câu hỏi thêm về vấn đề của HFO thì anh chị cứ gửi email đến em, thì em sẽ dịch sang tiếng Anh hoặc tiếng Nhật xong và gửi thầy Nakagawa sẽ trả lời các câu hỏi của quý anh chị. Em một lần nữa rất là cảm ơn quý anh chị đã tham gia ngày hôm nay.
Vâng, cảm ơn các anh. Thank you, Dr. Nakagawa.
Thank you everyone.
Thank you, Dr. Nakagawa.
Thank you.
Dr. Satoshi?
Yes?
You plan to Vietnam?
When, yeah, if there's a chance, I will.
Okay, so we'll go to offsite in World Week, July, or you just stay online?
I should stay online.
Okay, so it's all online, right?
Yeah, all online, yes.
All right. Okay.
Thank you.
Thank you very much.